I would joke that we saved the best for last, but this has probably been the best work day of my life, and it's all been great. So we have another great panel that will be moderated by my friend and colleague, Mr. Joe Tinsley, the manager of Drug User Health Services for Public Health Seattle and King County. I hope I got that close to right, even though he just told it to me 1 minute ago.
Pretty good.
And so he has a great panel where we're going to talk about harm reduction services. So take it away.
All right. Well, thank you for inviting me to moderate this this group. It's one of my favorite topics, and I've got the privilege to have all these wonderful panelists who I've had the privilege of working with before. So let me do some introductions. We have Shilo Jama, who is the executive director of the People's Harm Reduction Alliance. He's also the founder of the
Urban Survivors Union.
Thank you, Urban Survivors Union. You told me that right before we came in. We've also got Vanessa McMahan, who you heard earlier this morning, if you were lucky enough to catch her presentation earlier. She is a research coordinator at the University of Washington and recently completed her PhD in health services at UW. Round of applause. Her research focus is on methamphetamine use, primarily pre-exposure prophylactics or PrEP among cisgendered and transgendered individuals who have sex with men and use methamphetamine. She's also a volunteer over at the People's Harm Reduction Alliance. And last but certainly not least, rocking some awesome purple hair, is Peter Cleary. Peter left a 30-plus year career in the service industry to follow his passion for harm reduction work and became a peer educator at Project Neon. After several years working with the program and as a volunteer with Seattle Counseling Services, he assumed a full-time position there as their harm reduction program assistant. So welcome, guys. Up first, we have Shilo Jama. And he is going to be talking about meth pipes and meth programs, why you should start them, what they offer, and how you will evaluate them.
Hey, everyone. So I brought a little show and tell, and there are not enough meth pipes for one per person. So and I feel like it's really important to see and touch what services we do. And so after I'm done, I'm going to get up and I'm going to start passing them around, and everyone can hopefully look at it. And if you don't get it to the back, someone pocketed theirs for later use. Why smoking? So I can tell you with our crack pipes, I had spent most of my life working at a syringe exchange. I've done 24 years at a syringe exchange program, and I have been an active drug user off and on most of my life. I've been primarily in my life an injector. It was in injecting worlds. You kind of laugh at the smokers and you say, you only, if you really want to get high, you do injection. And it's a culture that came out. And it was one of those things that when we were trying to stop HIV and hepatitis C, it was all about the needle and all about that. And one of the things I think we totally missed was that smokers have needs. Smokers have health prevention services they need, and you reduce your use also by smoking. And so so when we started, the story I like to say around the crack pipes is a guy came up to me and said, I want you to know that you're a real motherfucker. You say you care about drug users, but what about my health needs, and what about my services? And I told him he was right. And I asked him for an education on it, and we slowly started developing these crack kits. And one of the things when working with cocaine users, they would say, one, they didn't know they had any health risks. Two, they most of them had never even been in a health service program or had been tested for hepatitis C or like all the linkage to care that we could do, right? The other thing, just with stimulants and other drugs, there's a lot of stigma towards stimulant users particularly, and I think some of that is because if someone has been up for many days and kind of seeing things in the corner of their eyes, they're a little more noticeable of strange behavior, where an opiate users can just kind of be in the corner and kind of look like they're almost asleep. And there's a stigma around opiate use too. And so one of the things I like to remind is when we handed out these crack pipes, the Chamber of Commerce of the University District Business Association called me and said, hey, why are you handing out crack pipes? I didn't think we had that many black people who lived in this neighborhood. Wow. And so, this was not that long ago, and so I think there is that stigma, And then when we started handing out, then when meth, people started coming to us and saying, hey, I'm getting needles because I don't have access to a pipe. And if you think of the HIV rates that you can get around injection, and hepatitis C, and really the short-term risks of injection. Now, if we were in perfect scenarios, you could argue that maybe injection is a little safer in perfection. But once you go down away from perfection, it gets a lot safer. And one of the things that our participants would tell us is when we started handing out pipes is they could make it to their doctor's appointment. They can make it to their, case manager appointments. They would just get high enough, to get them going down the road. And if you think of drugs as like, if you do too little, they're not that fun. If you do too much, they're really scary. Your just right is maybe not my just right. And so why are we pigeonholing everyone to an injection service system instead of keeping in mind smokers? And so these have been wildly popular. And I can tell you, with zero education, just providing this pipe, we had 30% of our meth users transfer immediately to smoking, right? Imagine if we did education and services. And the last thing I'm going to talk about is my trip to Portugal. And my trip to Portugal, the thing that I was most shocked with is they don't have young injectors. By large numbers, young people don't eject at all. They smoke. And they don't even have the quality of pipes that we provide here. So they've been able to get people to switch, an entire generation of folks to switch. So if you're an ejector, you're more likely my age. When I was talking to the Lisbon Syringe Exchange, I asked them how many needles they gave out, and they said, we give out about 100,000 syringes. And they're like, and I was like, that's nothing. Like this town gives out, 8 million, 6 million syringes? And they said, yeah, because our young people don't inject, right? It's only older drug users like you who inject. Everyone smokes, right? Because we go to the encampments and we've done the education and we've done the services. And so if you think about the next generation of drug users, the last thing I will kind of end with is, do you want them to be like me, knowing more dead people than living people? Do you want them to have, constant trauma in their lives? Or do you want them to give them a better opportunity for more health and that they can choose to use drugs and to stop drugs on, putting their health in their own pockets and having honest conversations with their doctors around health and prevention? So that was just something that I would hope each one of you would answer for yourself. And I will start passing them around, and I will pass the mic.
Vanessa?
Hi again, everybody. Thanks for having me back. What do I do? Any button? Oh, wow, okay. So I'm going to talk about pre-exposure prophylaxis, or PrEP, among cisgender men who have sex with men who use methamphetamine. So earlier, I brought up being cisgender men who have sex with men as well, and the reason I specify is because a lot of our research excludes trans folks, and so it's not because I want to specify this community, it's just because the data that I have at hand is kind of inclusive only of cisgender people. So one limitation at the end I'll come to is that we really need to be doing more research in the transgender and genderqueer community who use methamphetamine. So for this talk, MSM means cisgender men who have sex with men. So as Sarah Glick talked about this morning, HIV rates among MSM who use methamphetamine are very high in King County. It's estimated that methamphetamine is associated with 16% of new HIV infections among MSM, and men who have sex with men who use methamphetamine are 5 times as likely to get infected with HIV in Seattle or in King County than ones who do not use methamphetamine. The prevalence rates among men who have sex with men who also inject, as Sarah talked about this morning, are 40 to 45%, which is staggeringly high for the United States. Right? This is staggeringly high for many parts of the world. So it's a subgroup that has a really high rate of HIV. So kind of what can we do about it? So one strategy that I've been working on for many years is pre-exposure prophylaxis. For those who do not know what it is, it's when HIV negative people take an HIV medication, an antiretroviral medication, to prevent HIV. Currently, the only PrEP approved, the PrEP agent is called Truvada. It is a daily oral pill. There is a very expansive pipeline of research happening right now for injectables and implants and microbicides. But currently, when we talk about PrEP, we're talking about a daily oral pill. So this is our formative work we did, collaborating with Peter's team at NEON, who are such fabulous collaborators and participants of our work. So back in 2015, we realized that even though there's a huge rate of HIV in this community, there's very limited PrEP uptake. So this is old data, but it's data that was the basis of the work I'm sharing today. So at Gay City, where my principal investigator has a safety net PrEP clinic, they had 2% of people who were reporting methamphetamine use, later on 8%. And then Washington State PrEP app, which covers the expenses of PrEP, had 1% of the people they were covering reporting methamphetamine use. So our really low rates of PrEP uptake in this population. So what we wanted to find out is why there's such little uptake. So between October 2015 and April 2017, we did 2 surveys with cisgender men who have sex with men and transgender folks, looking at awareness and interest in PrEP, and 4 focus groups with the NEON team, the NEON peer educators, which Peter will talk about in the next presentation. So our baseline survey of 221 people who used meth, 97% had heard of PrEP, 97% had insurance, mostly Medicaid, which covers PrEP completely in Washington State. Another reason why Washington State's healthcare is really great for a lot of these services. 93% knew where to get it, but 3% were using it. So there's this huge gap between knowing about it, having insurance to cover it, knowing where to get it, but not wanting it. So we wanted to understand this more. So what we did was talk with the peer educators who are key informants and have a lot of experience, both themselves and with their communities around this issue. And I'm kind of putting 4 focus groups into one slide, so it's very brief. But the main findings were, unsurprisingly, that stigma is a barrier across the whole continuum related to multiple marginalized identities. So intersectionality of LGBTQ identity, drug use behavior, houselessness, mental health, that exacerbates the experience of stigma. So it was a barrier to getting HIV testing. I don't even want to go to the doctor, to telling the doctor that you're someone that might be at risk and be a candidate for PrEP, to adherence to the whole entire continuum of care. Then specific to methamphetamine, we heard a lot about competing priorities. Why would I go to the doctor when I can go to my dealer and get high? I'm dealing with these 2 options. The getting high one sounds better to me. Kind of myopia, once I get high, all I want to do is get high and have sex, and for 3 days I don't think about anything else. Difficulty making appointments and planning. So, it's Monday, the next thing it's Wednesday. I wasn't really realizing Tuesday happened. How do I take a daily pill if I kind of miss a whole day and I'm not following time? So whenever I present this data, I like to have quotes because this is the core of what we're talking about, and they can tell it better than I can. So 2 quotes to share with you. I make sure my doctor doesn't know that I use meth. They don't need to know that. I would never admit to it, because if you do, there's all sorts of consequences. The second one is stigma. I guess when PrEP is such a specifically used drug, especially if they're gay and IV drug users and all that, they may not want to tell their physician that they want to use PrEP because they have that idea that they're looking at them like, you're a drug-using man whore. So reasons why people are not sharing that they might even be eligible candidates for PrEP. So the suggestions from the peers, which we've actually taken to build off most of the work we've done since this time, is to try to reach younger men who have sex with men before they initiate meth and kind of have the impact of meth on their lives and create routines around meth. To increase testing, if we don't test folks, we're not going to find people for PrEP. We're not going to know they're negative or be able to engage with them. It's a community that has a lot of lack of testing. Accurate information is needed, especially how to afford PrEP. There is ways to afford PrEP in Washington State, and most folks felt like they could not afford it. And then provide PrEP in other settings where MSM who use meth are, like the bathhouse. We unfortunately have been doing that for quite some time and have had very limited uptake. Another question we want to try to answer. Identifying non-judgmental providers, and then supporting PrEP adherence and persistence among folks who may have challenges with time and with the daily pill. So just to follow up with a few slides on what we've done since then around some of the similar work, Sarah Glick talked this morning about the National HIV Behavioral Surveillance Survey. We use data from 2017. It's an annual survey that looks at different risk groups at HIV across the country in 20 cities. We added 5 questions about PrEP and meth to the local questionnaires in Seattle, Portland, and Denver. And we compared PrEP awareness, use, and reasons for not using it, as well as challenges among those that did use it, between men who have sex with men who had used meth in the past 12 months versus other MSM that had not used meth but met other eligibility criteria for PrEP. So condomless anal sex, bacterial STI, things like that. So these are our demographics. Again, the red boxes just kind of show you what's significantly different. The group on the left right here is the folks that use methamphetamine. It was 88. It was about 10%, which is kind of consistent with data we see out there on meth use in the gay community. More were from Seattle than Denver and Portland. Oh, that box kind of got messed up. Sorry about that. More identified as straight or bisexual than gay or homosexual. And more were white versus the folks that did not use methamphetamine. This one I did not put any red boxes because it's all significant. By far, the group that reported methamphetamine use had less education. The homelessness difference was, I think, massive. 4% of those who did not use methamphetamine did not reported homelessness in the past year. 35% of the group that had used methamphetamine reported homelessness. So we talked about housing earlier, and this is also, consistent with this data as well. And then health insurance was slightly lower in those that use meth. So when we looked at the PrEP continuum of care among these 881 individuals, the dark gray bar is the people that had not used methamphetamine. The striped bar are those that did. We really see similar stuff. So it's very inconsistent with our earlier survey where everyone had heard about it, very few had used it. Here we're seeing really similar results. There was a significantly lower awareness of PrEP among people who use methamphetamine, but otherwise things were similar. However, across this cascade, you're seeing huge decreases from awareness to discussion with provider to use of PrEP. And just a reminder that everybody in this sample met eligibility criteria. So we're reaching about between 30 and 36% of folks that are reporting active risk for HIV with PrEP. We asked folks, the 525 that did not use PrEP, why they didn't. In both groups, they said their risk was not high enough to be on PrEP. Again, we were using people that met eligibility criteria. So I think it begs the question of, is the eligibility criteria accurate or is self-perception of risk accurate? We see in a lot of settings that perceiving your own risk accurately is actually really challenging. Worrying about side effects was the second highest reason. And then among people who use meth, not thinking it was effective was the third and was significantly different. So 38% of people who use meth thought that PrEP didn't work to prevent HIV versus 19% in the other group. So the next steps that I see from this data is that I know it's kind of a simple answer, but I do think we need to increase education. Medicaid covers PrEP in Washington State. Gilead, the manufacturer, has assistance programs. Folks do not know about these programs, and affordability is a real concern. And among folks who use methamphetamine especially, information on efficacy I think is really important. To better understand this perception of low risk among MSM who meet eligibility criteria, we also see this in the bathhouse. Folks say they don't want PrEP because they're low risk. And maybe they are, but the bathhouse is typically an area where there's some HIV risk happening. So this is not just in this sample, we're seeing this locally, this idea that I'm too low risk even though I have HIV risk behaviors. And then one thing I think is we really need to look in other samples. So our Neon sample was recruited through the peers doing a needle exchange. So those folks were using meth through injection and really frequently. The NHBS had most people that were using it less than once a month and maybe smoking or injecting, mostly smoking. And so these are potentially really different subgroups of MSM locally, and I think might need really different services. So I think it's important to make sure we're always kind of including different samples, and especially the folks at highest risk, which I do not think are represented in the second set of data as much as the first. So thank you very much to the University of Washington, Caleb, and Joanne, the NHBS team, Project Neon, who are awesome, and then the research support from ADAI.
Next up, we have Peter.
Thank you. First of all, thank you for inviting me and letting me be here. I'm very humbled and proud both to be sharing about NEON because it is a terrific organization or program. We are housed at Seattle Counseling Service, and which is pretty terrific for us because there's it's easier for us to be seamless between harm reduction and some of the other services, behavioral health services, that kind of thing, so, which is nice. But for those of you who don't know, Project Neon is a peer-led harm reduction program, and it is very much in the community. We offer all the kind of services that you would expect at an SSP, needle exchange, education, safer sex supplies, referrals to services, that kind of thing. The difference is that we engage a group of spectacular men and women, volunteers, who take the materials and the information that we are continually training them to understand and know, and they take it out to their social circles, the people that they hang out with, and into the world where it is most needed. So I don't see it per se, but it goes directly to the bathhouses, it goes directly to the private parties, it goes directly to the tent cities, and it oftentimes is the first time some of these people are getting access to clean injection materials or education or knowledge about HIV transmission and that sort of thing. We have been around since 1993 at the height of the HIV/AIDS epidemic, and that is exactly what we were funded for, and it was a very tight focus. We were MSM, meth users, and we were HIV prevention program, pure and simple. We, in the last couple of years, have changed our funding a little, and we are now drug user health, which it gives us the potential to open up our services or expand a little bit to who we serve, and I've been trying to actively recruit new volunteers that are not necessarily MSM, particularly in the trans community. As Vanessa mentioned, there's a great lack of both knowledge about and I think services for a hugely marginalized group, but also for sex workers and transactional sex people out there. I think that's a huge issue, and again, stigma and stereotypes have come up all day, and yes, that's a huge thing, but drug use stigma, and then trans stigma, and then prostitution stigma, and I use that word intentionally. Suddenly these people feel very alienated and very unable to even be worth the effort to get services, much less find them. So that is something that we're doing, or I'm doing a little bit more actively right now. The great thing about some of my peer educators, I have one who has been with the group for 19 years on and off. So we have some really good longevity. We also have new peer educators. We've got, I think, 2 right now that are like 6 months or 8 months. So they get a really good, there is trust in the community. Even if somebody has never been met, if they say they're from Neon, there's probably somebody in that group that goes, we like you already. And the new blood is always kind of reaching new markets and new places. And I think very often when I'm in less good company, I sometimes get accused of supporting drug use and all that promotional crap that we don't do. And but I think very often really grassroots things like what Shilo has always done, what we've always done. I think that's the first time people come to both realize that they are worth, have enough self-worth, and have enough, they are worthy of these services. And I think that oftentimes gives them the strength to seek things out, particularly now with all the other combination things going on, and homelessness is key. I know it's been said about 16 times today, but if we don't get this homelessness thing done, none of the addiction services are going to be, as valuable as they could be. Throwing money at that one, anyway. And since I'm on a soapbox, I might as well mention the other thing too. We also need to do some serious changing of paraphernalia laws, just the whole punitive, you throw them in jail kind of behavior. It only intensifies the problem, both when they get out of incarceration, but also just on this, again, it's a self-worth kind of thing. But when you read the WAC about paraphernalia, I mean, your kitchen sink falls into that classification because it could be used to manufacture. So there is very little that can't come under that law, and I think it's way too broad, and I think it is, arresting somebody for having what Shilo just passed around the room, because you could all get, that is insane. So we need to back down off that, constantly going after the criminal and more try to service the human behind them, because there is nobody out there that is reduced to a single activity or life choice or characteristic or anything. They are whole people with whole stories and worth being on this planet. So that's my, in a nutshell.
Thank you. Questions from the audience?
Wow, everyone knows everything about methamphetamine service?
Oh, we got one in the back.
Hi, this is Allison Newman from ADAI. I was just wondering what you see as the gaps in harm reduction services that we should be considering when we're planning programs.
I have the great pleasure to work with an organization where I'm integrated into a lot of behavioral health and other programs. That said, I am very envious of the gentleman at the other end of the table, because we're constantly doing the harm reduction, and currently, right now, I do needle exchange, but that step down from needle exchange is pretty much abstinence, and as we know, that isn't really viable for many people. For those who get it that way, that's awesome. But it would be great if, and it ties into the whole paraphernalia laws. If I had a way to get them off a needle, or at least reduce the amount of times they use a needle, and work it down that way, that would be amazing. So yeah.
I was going to add kind of one thing. I've been rereading other focus groups recently and realized there's populations that aren't touched at all. And the population that was most recently what I was looking at was survival sex workers who kind of just live drug dealer to drug dealer, live in a van, won't go anywhere, won't go to any doctor's office. An interview I did with this lovely young trans man who basically said, I stay home all day, I go out at night, and I go back, and it's not their home. So I think that there's definitely folks out there with really high acuity that maybe very few of us are touching, if at all. And so I've been just thinking recently of how do we touch those folks if you're not getting any services. So it's kind of a part of answer your question, Allison, because there's other things we can do to improve our current services, but I also worry that there's folks that we're not even touching.
So I think, there's a serious lack of syringe exchange services in King County, and because we only have 3 to 5 physical sites and some delivery services. But what we don't have is syringe exchange at all of these other systems, like all the shelters, all the housing facilities. And then we also don't have, we are the only pipe distribution point for the city. And so, for example, if you think of disease prevention, if you smoke, you have to come to us. And so most of disease prevention systems is you want to go out to the community, because you're not going to see everyone if everyone has to come to you. And if you think of pockets, say you have a group A might have Hep C in its cluster, right? And group B might have HIV, and now you're having group A and B mingle with each other because they have to go to a centralized point. So having as many points as possible to have services and smoking services, and to saturate the market. I mean, we still haven't even saturated Narcan in this city, which, there's really talented people constantly focused on trying to get Narcan out there, and we still can't saturate it in this town. So, we're still a lack of services. Also, snorting kits are out there. We have them, but, and we're in the university district, and shockingly enough, a huge portion of the university students grab our snorting kits, but just having them in all aspects. And, there are so many different programs. We actually have less sites now than we did, 15 years ago. For syringe exchange. We now have 2 great delivery services, but we've kind of learned the delivery services aren't very good at engaging homeless encampments unless they go and stop at services. And so we do need a big infrastructural system. Simultaneously, we need to really focus on what treatment on demand, because there's so many people every single day at the syringe exchange, people are asking for treatment. And I think it's embarrassing to me that, through all these things, we can't provide treatment for everyone. And I know that every year we're getting better and better and better. But, what is the treatment for Snoqualmie Falls? Like, where's the treatment for if you need treatment downtown Bellevue? Like, our services shouldn't just be downtown Seattle. What we probably need is kind of a homeless drug user health center system. We probably, at minimum 20 locations that are clustered in 20 different parts of the county that you could go to there to seek services. And then once there, you can go out to primary care and other systems. So we have a long way to go. Saying that, not to end on negativeness, we've done a lot of great work, and there's been a lot of innovation in this town done by government and private individuals who have gone above and beyond in doing services.
And I would like to add to that. That's true. I just got a call. It's dealing with contact. Anyway, South King County, the decision to drive into or commute into Seattle or go to Tacoma, and that seems really insane since it's not a tiny little place that nobody's heard of in Eastern Washington or whatever. And we are making progress, because I know there's several of the DESC buildings, and Neon right now I'm providing equipment for them and syringe disposal and that kind of thing, and they're being a lot more open about sharing that with their residents and taking some of the shame and stigma and punitive actions against their residents. So I did want to mention that too. So,
and I would just add, I think funding is also an issue, right? To be able to do all these things and reach more people, we just need money to be able to do that. And with the way the city is growing up, it's harder to be able to site exchanges, places. It's certainly a challenge to find a brick and mortar locations. So I think that's one of the big challenges is funding and just how the city has changed. Question back there.
I guess I can go because I have the microphone. So Sasha, I'm with Coordinated Care, one of the managed care organizations. So just a question. I really appreciate what all of you are sharing, and I'm a total believer in harm reduction, both in my clinical work as well as in my now kind of managed care experience. I'm wondering, I think, even though there may be differing perspectives within this room, I think a lot of us are probably like a consensus and a lot of kind of evidence-based interventions around treatment here. I'm wondering if you have any advice for us when it comes to bringing along those who maybe have more like retrograde or outdated perspectives on abstinence-only programs, in particular when we are working with residential treatment programs, withdrawal management programs, et cetera, that might still take an abstinence-only perspective, and if you've had any successes in kind of converting folks or bringing them along to a harm reduction model in your experiences that we can utilize.
I'm a big fan of science. And I think there are some really talented researchers like Caleb here and Susan. And so bringing science-based service. And we have more and more science around service. I mean, to be perfectly honest, our mistake around crack pipes and meth pipes is we didn't do the research before we gave the service, we did it after. And we're correcting that with newer services coming forward. And so it's about doing some research. And it doesn't take a lot of money. I think ethically you should pay participants, and we've been able to nickel and dime some surveys out there, and so to get more kind of knowledge out there, and all you have to do is do a small little paper, and that can be the pretext for a public health entity to do a bigger research project on that. And then and remember, for me, my value about research is don't ask questions you don't intend to use that will better the lives of the people you're trying to survey, right? Don't ask questions just because you're interested, right? And so I think that is important. I also think, and people are going to be shocked when they hear this, I think working with your government institutions as a nonprofit is really, really important. And I think collaborations are really important. So.
And can I just add, as somebody who's been doing this, the surveys that Shilo's talking about, I hear a lot like, how do you reach people who use meth, or they don't want to participate in research, or all this stuff. And we've done like 372 surveys. I think we've had one question refused. Everyone has given us so much of their time and wanted to be a part of it. With Neon, we brought results back and we all collaborated on that discussion. I just think that this idea that I hear that people that are homeless or marginally housed and actively using don't want to participate is really opposite of my experience, that people want to share their stories, which we've heard across other panels. So doing grassroots research to create a bigger evidence base, because I don't think we have a big enough one, I think is really important and extremely possible.
You guys covered most of it, and I guess just coming back around to you're talking about the people that are hard to convert, is humanize the issue. So often it is this big scary topics, and when you humanize it, and again realize that Anyway, I think that's important to, especially for the more conservative people out there. Oftentimes, bring the problem home to a real singular person perspective is very helpful.
I mean, I also think this city has lost its outreach ability. I think we used to in the 90s all be about going to encampments, going to places, doing that kind of neon style of delivery service. And we've kind of lost that. We kind of have this system of like, you should come to us, and we've lost kind of the rabbis of those communities and those connections. And, working like at the U District Exchange, people would do surveys because we asked them to do surveys if they could, and we show and we give them that respect and dignity of folks who are coming there. So they already trust us, right? And they say, okay, I trust you, and there are going to be people who are just not interested for various reasons, and so I think just always finding those connections, and really we need to rebuild those institutions of going to the encampments, knowing people's names, having those connections.
Yeah, great. You guys are doing absolutely awesome work. And I'm just wondering if you could comment a little bit about what you think about public buy-in to harm reduction, and whether there needs to be more education efforts, I think, to the public to maybe then get you guys more resources that you need. And certainly I think ADI is always happy to help, but does that make sense?
Yeah.
Is that a touchy topic, someone coming from basic science? I mean, I think I see a disconnect, right? As a researcher, I know how important it is. And then I have the next door neighbor sites and the different sites, and there's so much misinformation out there that I think there needs to be a way to better convey the needs to the public and to really expand the services.
Yes, I think education is a key. I think, and educating on facts and not emotions, I think is, like a public health department's, bread and butter. And I think doing kind of anti-stigma work, and then also, understanding why things happen, and not kind of being this like, just because it came down from the government, but just to be like, here's our scientific reports, and this is why we're doing these things, and having community forums and listening to neighbors complain and trying to find answers. I think in this kind of modern kind of NIMBYism hate kind of place, we get into blame and anger, and we're not getting into like what's the solution, right? We're concerned with, for example, needles on the streets. Everyone in this room is concerned about needles on the streets, right? And so how do we prevent that? We create more sharps containers. We create more education. We change the paraphernalia law so people don't feel like they need to throw their syringes out when they're dirty. We have more pipe programs so people can transfer away from injection. And so all of that combined can be an education plan. But, we also need to be not stigmatizing the people we serve in that education systems. And, I will kind of tell a story. When I went to Patty Murray's office, this is about 6 or 7 years ago, she told me that I was the first person in a decade that came to her for any harm reduction services. And she said, you guys don't seem to have any lobby system. You don't seem to vote. You don't seem to be on my radar. But, all these other groups who tell me how bad and horrible you are, they're definitely on my radar because they come to me every year. So I think, talking to your legislatures, talking to your media, having that dialogue, challenging that kind of status quo, but then also having, people that can be kind of the more centrist and the more left and right wings of your political affiliations, and really having this. And also not trying to make your camp in the Democrat or the Republican. We need them both. And we need, doing health prevention is not a partisan issue, right? People get HIV regardless of their political affiliation, and we need to really, that needs to be the message. This needs to be about public health and about public safety and all of these systems. So it's about that kind of education. And try not to go down the rabbit hole of some of the NIMBY Facebook groups.
So, with regards to PrEP, I think public buy-in has been a real rocky course since 2012 when it was approved. So there was very little uptick across the board the first 2 to 3 years because we didn't have provider buy-in and we didn't have public buy-in. And it really took like a lot of efforts. And Gilead was not doing advertisements and was not promoting it. And so now in 2019, we've had huge increases on prescriptions across the country. And there seems to be kind of public agreement that it's not going to increase risk disinhibition. People aren't going to go out there and have condomless sex every single day. HIV rates are not going to skyrocket. We're monitoring and looking at data around STI rates. But now we're kind of at a new phase of public buy-in where we realize that that's really only happened in like Seattle and San Francisco and New York. And currently 1 in 10 white gay men get HIV in the United States, but 1 in 2 black gay men get HIV. And so we have this huge disparity. And so I think that what's unfortunate about it is we finally got public buy-in, but it's really only happened in certain places. And so I think the challenge now is how do we get that public buy-in in places where we don't have Medicaid expanded and access is really limited. So there's still kind of a lot more to do.
Also with that, I think a lot of times you get people that are, I think harm reduction is great, anything, but not in my backyard or not in my neighborhood or don't. And I think that's ties into all that too. We're not reaching the people we should be reaching all the time, and it is not pervasive enough. It is not universal enough. There should be. Our services should be at every public library, every school, and they're not, and that's unfortunate. They're.
I have one more thing to add just to that question. I know at least your program and my program have very robust volunteer components, and so a lot of the volunteers are students. So getting the students when they're young so we can sort of brainwash them into treating our folks the way we want them to be treated, particularly doctors-to-be, nursing students, pharmacy students, folks that are going to be in positions to make decisions and in positions to provide hopefully good, competent health care. So I think that's an important component. I want to thank our panelists. You guys are awesome and rock and do such great work. Thank you so much.